So welcome, Dr. Cindolo and Dr. Cash for this episode 2 of the podcast of prostate cancer prostatic disease. Today we will talk about primary bladder neck obstruction. So I can ask you both to introduce yourself. So first, Dr. Cash, what do you work and what do you do?
Yeah, so I'm Hannes Cash. I'm a urologist in Berlin. My main focus is BPH and treatment of prostate issues with minimal invasive therapies and laser enucleation as well. But I also focus on a lot of diagnostics and prostate cancer diagnostics with targeted biopsies and imaging. So besides BPH, imaging is one of my main things I'm interested in, also research wise as well.
Okay, and Dr. Cindolo?
Hi, it's Luca Cindolo. I'm based in Rome. I work as urologist, chief of Department of Urology of a private hospital called Villa Stuart. So my main interest is around the prostate. I'm honored to be also assistant editor for prostate cancer and prostatic disease. And I'm focused on the prostate, of course. Mainly BPH and lower urinary tract disorders, but also prostate cancer.
Okay, very good. So I will start with you, Dr. Cindolo. What was the input for this interesting review that may revolutionize completely the pathophysiology of PBNO? Can you tell us something about it?
Yes, the interest around the PBNO, the primary bladder neck obstruction, comes from clinical observation of a lot of patients suffering, young patients suffering of lower urinary tract symptoms, mainly obstructive, with inflammatory condition in coexistence. So the idea at the beginning was to better define the clinical and physiopathological pathway they have, moving from an hypothetical infection, especially in the young age, that will transform the prostatic environment toward a more fibrous tissue, generating obstruction and then generating lower urinary tract symptoms. The idea comes from clinical observation, but now we have some pieces of this complex puzzle, and we hope this could be also helpful for other clinicians around the world.
Okay, and Dr. Cash, what is in your clinical practice the impact of PBNO? What's the epidemiological impact in Germany, for example?
So as Luca pointed out, I mean, first actually it's really understanding that BPNO exists. I think a lot of urologists don't acknowledge that we have these problems, but we all know these younger men in their 50s or sometimes even late 40s who present with residual volume, a destroyed bladder structure on the ultrasound, sometimes even diverticular, but a very small prostate. So things that usually don't fit together. Where it's sometimes hard to understand what is the underlying pathophysiology behind these cases. So at the moment, I think overall, I think it's an underestimated disease because a lot of urologists don't acknowledge that we have this problem. So as Luca pointed out, the first match is really to understand the potential underlying issues and align those with the cases that we see. So I would say I probably see about 10, 20 cases a year and I do a lot of BPH surgery that fit into this category. And maybe even some years ago, I was not really focusing on this kind of disease problem as well. So I think it's an underestimated cohort. But as we focus on it more, I think we'll get more aware and see more and more of these patients in the future.
But do you do because, when normally, if you agree, there are Pauci symptomatic patients that don't have a lot of symptoms. So normally in your clinical practice, how do you identify them? Like in screening programs or they come for other reasons and you find them having this syndrome?
So I have a lot of patients I see as a second opinion in regard to surgery. Of course, those are the men who've already gone through the whole process and already have destroyed bladder symptoms and LUTs as well with a small prostate. So we identify those men who already have it. And of course, then you have those younger men who presented their, 40s saying, okay, it's already changing. My habits are changing, but you don't see anything yet, right? And then let's go, of course, and we'll talk about this in this podcast, is also questioning disease, lower urinary infections, maybe even STDs or prostatitis. So just to be able to focus on these symptoms, to find out the patient who is at risk of developing BPNO.
Okay, good. And Dr. Cindolo, what are the other theories and that are available about pathophysiology? What are the main theories of this sort of syndrome that affect mainly young men?
There are at least two theories historically recognized. The first one is that the primary bladder neck obstruction is a congenital disease. So this is the reason why sometimes this condition could be observed in child or in young men without history of infections. This is a good theory and probably still present, especially in pediatric urologists. In pediatric urology, this could be observed, and cystogram, urodynamics, and also cystoscopy are necessary to identify as soon as possible this condition in order to treat this condition and relieve the obstruction for the better health of these bladders. But another theories that historically is recognized is that the primary bladder neck obstruction comes from also a changes in terms of balance of the skeleton. So something in the middle between osteopathy and peripheral autonomous nerve dysfunction. This has been recognized, especially because some treatments helpful in relieving symptoms comes from this kind of methods. But at the end of the history, we think that the pathway we should reinforce is exactly moving from an infection that transform the tissue during the years after the first prostatitis.
Okay.
And this is the main key of the prevention and treatment, but we will see this later.
Okay, so tell us, Dr. Cash, how do you think we can prevent? Because this is, I think that the big thing that changes the paradigm of this theory is the fact that maybe we can, if it's not a congenital disease, something that we probably studied in the books,
Yes.
probably we can do something about it. So what can we do to prevent such a disease, which can have actually sometimes dramatic consequences on the urinary tract?
Absolutely. So, I mean, as Luca pointed out, looking at the focus as infection point is going to change also how we have to look at the patient, what tests we have to do. So I think it's important for men who present with prostatitis or infection symptoms early on to do urinary cultures, also ejaculate cultures as well. To be able to treat antibiotics directly to target the right treatment. I think that in the past, a lot of young men don't get cultures. They just get antibiotics, wide, broad antibiotics without any targeting, and also anti-inflammatory medication like ibuprofen or other NSRI, I think will be a key in this. Of course, we have no data because the whole thing, I mean, we scanned the whole literature, is very scarce. It's underreported. As researchers, we focus on the diseases that are oft common and we have a lot of cases of. So I think that's one of the main problems as well moving forward, that we'll have a short, a really limited cohort, a data cohort to focus our treatment changes on.
And Dr. Cindolo, what do you think about this? How would you change something? Would you do something to prevent such a disease, like campaigns in terms, because what we usually see is that normally different from the gynecologist, urologists actually act in men later on. So what's your thought? What are your thoughts about actually preventing these diseases. Also, because in your theory, what's interesting, it's a lot about infections and inflammation. So probably we could do something more for young men. What's your opinion, Dr. Cindolo?
Thank you for the question, because this is the key of the problem. The problem is not the management of infections or the prostatitis, but the problem is still, in my opinion, in urologist attitudes. Traditionally, the urologists prescribe antibiotics because the prostatitis are so common. The patients are very bothered from the symptoms. Sometimes this could be even boring. In our part of the work, have a patient with prostatitis, especially chronic prostatitis, in our consultation, in our office. So I think that as urologists, we should force ourselves to change our mind, moving from a less pharmacologically oriented attitude to a more clinically oriented, microbiological oriented therapy. Of course, we have antibiotics. We know that the antibiotics could be also very dangerous for our health, but we perfectly know that the protocols for eradication of bacteria from the prostate are protocol very long, 28 days. And if you ask every patient with the PBNO, he will reply to you that he did several courses of short courses of antibiotics during his life. And this attitude is very rarely, it's very rarely based on a culture with the identification of the target as antibiotics. So the time have changed. Now we have to change as urologists. This is my message.
Okay.
Don't abandon, don't suppose to be helpful in this patient just prescribing, but we have to check periodically the culture, especially for chronic patient. We should perform a better investigation and evaluate as soon as possible the presence of obstruction.
Okay.
Absolutely. So maybe I could add, we could also, also just do a wide STD check as well. I mean, in a city like Berlin, STDs are everywhere, and people are not using protection is the way they should. So, a lot of young people being very active will go through these urinary tract infections without noticing it as well. So this is something to focus on, especially if early micturition symptoms arise as well. One more point is that, of course, imaging is moving along as well. We haven't focused this in this paper because there's no data on it. But, micro-ultrasound is around. Of course, not everybody has this in their practice, but you can get a 70 micron definition of the prostate. You can actually see changes that align with prostatitis, like small singular calcifications that will go on and be not visible after treatment. So I think in the future, we'll have more and more clinical aspects that we can add to the culture as well to find out the patients who are at risk.
So, and do you think, because actually I was recently, they're doing uroflowmetry home-based, they're doing uroflowmetries in the public places. So do you think that it could serve as a screening to identify these patients early? Because if you actually promote doing simple flowmetries, or as many are proposing, there are a lot of different ways to perform flowmetry, not classically, let's say, with other types of technology. So do you think there is a place for it, or is it too expensive? Do you think that it's difficult to actually put in place such a screening? What do you feel about this, Dr. Cash?
So I think Euroflow is quite important. Also a protocol, just a micturition protocol to really understand where the problem is, with drinking habits and voiding habits, because these things usually come over a longer period of time. So you usually get the first question I ask, like, how's your voiding? They're going to say normal, because for them, going 10 times a day is normal. So having just the protocol will help. And I think as we move, sorry?
Even taking a minute or so for micturition is normal for these patients.
Exactly.
It's very difficult.
So it's really asking the right questions is the first key, of course, getting the protocol, and then flowmetry at home. I mean, as devices get cheaper, you know, you can get an ECG just on your wrist for like 100 euros now. I think the future for urology has other applications that we can use much more easily with an app or something to have patients screen. But I think younger men, even screening for testicular cancer is not so widely accepted. In Germany, is also not reimbursed. So we have an issue with young men be getting checked rather than young women going to gynecologists. Young men usually don't go to the urology department early on. So maybe that's one of the main keys. But here we're talking more politics than anything else.
Okay,
Ricardo,
yeah.
Ricardo, about screening, we know that PBNO is not so common. I think a real program of screening for this kind of problem, it will be critical and difficult to apply. But as you are just citing before, the use of instruments like Euroflowmetry in public toilets or on the highway, you know, could be of interest. Just putting an alarm just to say, okay, this micturition is not good, please go to your urologist for a check. This is an old idea, but I think now with the new technology this will be helpful for public health. You know, I'm passionate of that. I think in the future we will also help a lot of guys with problems.
Yeah, I agree that it's a big area of unmet needs. So I believe that for that, I think that your paper is fundamental to highlight a little bit more on this poorly studied disease. So I would ask you some few questions more. So I just want to know, if you, Dr. Cindolo, actor for the treatment, we don't have a lot of options. So I would like to know if you prefer to go unilateral incision, bilateral incision, if you decide to go for an incision, obviously, and if you prefer to use a monopolar, a bipolar instrument, or a laser. So that's what you usually do, because as a matter of fact, we don't have a lot of data on this disease. I mean, we don't have a lot of randomized clinical trials. There is very poor long-term data because we don't know if these patients develop or not BPH, because normally we treat them around 40, 45, and we don't know if they might develop BPH over the PBNO. So I would like to know how you treat them surgically.
If the case is suitable for surgery, as usual, I offer an incision of the bladder neck, mainly by laser for hemostatic reasons. But I think in terms of efficacy is quite the same. The question of monolateral or bilateral, it depends on the propensity of the patient to risk the loss of ejaculation or a reduction in semen volume. So mainly I perform an incision of the bladder neck with laser. This is my definitive answer.
And I have a question. What do you say to patients is your rate of ejaculation, of retrograde ejaculation in monolateral incision? Because here again, there is not a lot of literature. So I was worrying, what do you say? Do you say, I'll try? Do you say it's 100%? Because normally, 100%.
I might inform the consent. The informed consent I share with the patient is oriented on some report in the literature, and from some synthesis from the literature, I arrived at 10%, 10 to 15% of loss of ejaculation after monolateral. But the bilateral incision, this number increased a lot.
Yeah. I know that. That's a big problem. The other thing that it's lacking in the literature is that we don't know how much more effective is the bilateral than monolateral. There's not really a consent on that. I believe that probably it's the same. So it seems to be equally effective, but obviously it depends also how deep you go as your incision. So it's not such an easy procedure, I believe, I think, because sometimes you might be tempted to resect, or it depends on because sometimes you have some BPH over it. So if there are young men, probably it's easier. But when you're talking about 50 something, it's become tricky, actually, even if I repeat, it's a procedure that from a surgical point of view has no really a difficult thing, but because you want to preserve ejaculation, and you know that when you want to preserve, there's always somehow you may undertreat patients. So, Dr. Cash, what do you think on MIST, so minimally invasive surgical techniques for such a disease? They might serve, actually.
Actually, they would. Luca and I, we discussed this also when preparing the manuscript. So the volume has to be in a certain size, because in smaller prostates where there's no BPH there, and we discussed in the paper, you have a lot of more like connective tissue rather than BPH. I think Resume may not be a good option, so you have to be critical of that. But the stents, I think, could be like iTind or the new stents that are coming in the market. Potentially, it would be an option as well. I think it's really important to understand the physiology and the pathophysiology of the patient. Also doing imaging, really to understand, okay, what does the transitional zone look like? Because some men have a small prostate, but will still have an enlargement of the transition zone. So the whole glandular volume may underestimate the BPH sometimes, as we all have these cases with, small prostates, but retention. When you go in and do enucleation, you suddenly have all this tissue that you start removing. And I'm going to get to the point where if you start doing the incision of the bladder neck, sometimes it may even make sense to resect the whole bladder neck, going circular all the way around, with preserving the apical part around the vira montanum to have antegrade ejaculation, more like an ejaculation preserving laser surgery, for instance, like we do in BPH as well. So this is something to apply potentially to the patient.
So do you always perform cystoscopy in these patients? I suppose,
yes. Yes, I would, especially if things don't match. So I would definitely perform an ultrasound, and not just look at the as I said, the total volume, but really look at the peripheral zone, transitional zone structures, and then do a flex cystoscopy for sure, just to really understand where is the obstruction and be able to counsel the patient, beforehand. Because I don't like the patient to go into surgery and say, I'm going to do this, depending on what I'm going to find. I'd rather tell the patient, okay, we can do a bilateral incision, or we should do a whole resection because you have some prostate enlargement as well. So this is to be discussed with the patient. Also, is there a wish to have kids in the future? We don't know how any procedure on the prostate is going to affect that. This is beyond ejaculation, right? So there's a lot of things that we don't know.
Okay, good. So what do you think, both of you, are the future perspectives in this area? What should we focus on? What should be our main ways to, because what I think it's important is that it's not easy to do the research in low prevalence diseases. So here, I don't know if it's difficult to perform. Most of the data will be retrospective sometimes, because it's difficult. As you said, you talked about 20 cases a year, which is even a high number for a normal urologist, because you normally don't see a lot of it. So what do you think are the next steps to improve the management and to explore better the theory that you have successfully published in our journal?
Riccardo, I think we in the future we will do better diagnostic pathway to the young patient. The awareness of the presence or the clinical impact of this disease should be raised in the population. So I imagine, for example, a campaign. Do you think to pee well? So come to us and check it. Okay, something like this, because we should avoid to lose the trussor function before 40, 50 years of age. This is very important. Again, in the future, I think the diagnostic will be more and more less invasive. I imagine, for example, electronic diaries instead of acoustic uroflowmetries, instead of some ultrasound scan that automatically will send us information about bladder wall thickness and the trousseau wall thickness. I think altogether this data will help urologists do a better work. As, of course, low prevalence diseases are difficult to evaluate. And I think for the moment, we have only the possibility to do retrospective studies. It is difficult to imagine a randomized studies on a so low prevalence disease. Anyway, the presence of MIST now are changing a lot our mind as urologists. And in the future, I hope to see new publications about, for example, the management of the small prostate.
Yeah.
Okay, so it is rare to have information about the management of prostate less than 30 grams.
Yeah.
In the literature, it's quite rare. Now with the IT, in the newsstands, incisions, whatever, probably we will assist in increase of a better definition of the small group of prostate, and probably the future will help the overall management of this patient in the big family of obstruction, urinary obstruction.
And
Dr. Cash, what are your final thoughts on this disease?
So, I mean, Luca already mentioned a lot of things. I think the only thing that we can, we've done in the past as well, is to get together in a group collectively, the guys who are interested in research, to combine forces. I think that's the only way to create some sort of a registry like you've done in Italy with Greenlight, with Resume, in the same way. And as Luca said, I think the entryway is probably not BPNO, because it's going to be too tough to get everybody on the same level with small prostates. And then because I would say that most of the time as surgeons, we only see the patients when they are really symptomatic and residual volume has gone up. And whoever's seeing them in their office is going to say, oh, you need some sort of surgery, go see them, go see the surgeon. And then we start thinking, okay, it doesn't match, he does a small prostate, but he's symptomatic. So I think we probably have to go on backwards to understand things better. In the future.
Something that it's missing also, because that's something, as we said earlier, I believe being very poorly symptomatic, these patients are difficult to convince to undergo surgery. So I really believe that somehow if we could find some medical treatment or something that it's accepted easier by the patient, because it's very difficult, because most of them, they have like 5 of Qmax and they don't care. I mean, they live well that way. I mean, it's very difficult.
Yeah, because it's been like this for 20 years, right? So they're happy with how it is. It only shows up when they start in their 50s to go for like a PSA check, and you do the ultrasound and you look at the bladder and you see the thickness of the bladder wall. That's when we tell the patient, you have a problem. But the patient never realized he had the problem. I just saw a case on Friday just like that, in his early 50s, diverticula, but no flow of 15, but no symptoms. So he's hard to convince for treatment if the patient that's why I think it doesn't pop up in daily practice, with time being scarce, 3 minutes per patient sometimes. The general urologist is going to be very tough to counsel these men. If they say they're happy, okay, good, see you next year. And this is, I think, a big main problem. And this is where technology maybe can educate the patient to see the specialist in this case as well early on.
Okay, so I think that it was a very nice conversation with you both. I think that we went through all the manuscript, and I believe that it is really an interesting area of research, different from what we usually talk about. So I think that our readers will certainly benefit from your review, and will probably open their minds a little bit more on such a disease. So I really believe, and I hope to see more systematic reviews on small prostates, besides the big prostates, what we are used to, that are probably more interesting for a lot of people. But I really believe that we can change a little bit the story of this disease with your theory. So I really thank you both for your Saturday afternoon, and hope to see you for our next podcast. Okay. Thank you very much.
Thank you, Ricardo.
Thank you,
Bye.
Ricardo. Thank you.
Bye bye.